first of all, I'd like to really, thank you all to join the 6th Complex PCI 2021. And we have a very interesting lab cases from St. Francis Hospitals, USA. Dr. Ajad Ali, Jihad Ali, will give us very interesting cases. And also I'm very happy to have a distinguished moderator, Dr. Shi Akasaka from Japan.
Yeah.
Many panelists here. Dr. An Jung-min from Asan Medical Center, Dr. Ajay Pertain here, Dr. Lee, Dr. Puri, Dr. Wong. So actually, join us together. So, all right. So, will you start the cases?
Thank you, SJ.
Right.
It's a pleasure to join you here from St. Francis. I'm here with Rich Schlafmitz. What we're going to do is present to a heavily calcified case. And we'll give you a little bit of background about the case. Go ahead, please. So a 79-year-old male with a history of peripheral artery disease, carotid stenosis, hypertension, hyperlipidemia, actually has a AAA endovascular graft and a few cancers, who came into clinic with fatigability, dyspnea on exertion, and chest pain for a couple months. He had an abnormal stress test with a normal ventricular function. You can see on the diagnostic angiogram, there's a focal lesion in the proximal posterior descending coronary artery. The ventricular function is normal. Next slide, please. But really the problems are this type A looking lesion in the LAD. You can see it's severely calcified, diffusely diseased, aneurysmal, and you'll actually notice that the angulation of this calcification in the LAD is potentially problematic. Next slide. So the patient underwent a PCI of the PDA with an effort to get complete revascularization and is now back for stage PCI of the LAD. Next slide, please. And I'm just going to let Rich talk to you about an algorithmic approach that we take at St. Francis, really trying to understand the calcium based on imaging on what we need to do next.
So around 10 years ago, we clearly recognized that angiography alone was not adequate to assess calcified lesions and or in-stent restenosis. And we've actually taken it to the limit now where we basically realize that there is no such thing as a simple lesion until you image. So 95% of our cases at St. Francis are imaged. And we feel that that's the correct way to get precision angioplasty without questions. It makes any kind of angioplasty more understandable, and it makes it complex more simple. With respect to calcified lesions, we break it up into our ability to image. Personally, I like OCT imaging because I could really define the calcium as deep, superficial, or nodular. And I have very clear-cut understanding of the size of my vessel, as well as the length of lesion to try to get normal to normal tissue. Especially with Shockwave intravascular lithotripsy, I need to know the true size of the vessel to get the maximal effect of the Shockwave. We try to get 1-to-1 in the areas we shock. In addition, with OCT, I could have co-registration. So I have 80 pulses per catheter, and I want to maximize my pulses where the most calcium is. In Shockwave, ideally, greater than 270-degree angular calcium is preferential where you want to shock to get the best effect of the energy. And if a lesion is long, as in this case, if there are areas that I don't need to shock, I want to concentrate on the calcified areas. So going to our algorithm, we break it up into A, if the OCT catheter can cross, we can assess if it's deep, superficial, or nodular. If it can't cross, we might need an ablative technique to first create a channel. But the important point here is that we never stent unless we image first, because no matter what technology we use, we want to document fracture to show that we're going to get full stent expansion with luminal gain, and we shoot for the Luminant 3 and 4 guidelines to minimize restenosis. So if you'd like to talk
Great.
about this.
Next slide, please. So a couple of focuses. Our plan here is a femoral access, 7 French, plus or minus a guide extender. We are going to be using the MLD Max intravascular imaging approach to determine our lesion preparation strategy. You'll see these two still frames. On the top frame, you'll see that there's a heavy angulation in the proximal LAD, which makes atherectomy potentially unfavorable and in fact, potentially unsafe. And therefore, our plan is, if we can deliver, to use a Shockwave intravascular lithotripsy to perform this PCI. So let me show you, if you can go to the angiogram, I'll show you what we've got to so far. Okay, so we have one LAO caudal shot, which shows that there's really some moderate disease in the proximal left anterior descending and proximal circumflex. But the problem is clearly in the proximal to mid left anterior descending with a very tight lesion, an aneurysmal segment distal to that. Now, angiographically, even if you have IVUS eyes, SJ, you really can't see what's normal to normal here and where to land the device. So what we've done is we tried to balloon this to make some space because we couldn't get our OCT catheter across. I think the proof is in this picture, which shows a severe dog boning and an inability to dilate the vessel despite a high pressure balloon. And so we were, however, despite this, able to sneak an OCT catheter across. And I'm going to walk you through the OCT right now.
We did switch for a wiggle wire to help us get with that OCT, and that's very useful in these calcified lesions to have the wiggle wire.
Okay, can you swap to the OCT, please? All right, so we've done one OCT run, and what you can see here is the longitudinal on the bottom, the automated measures cartoon in the middle section, and then the OCT cross-section of the angiographic co-registration. We can basically ignore any of this except for this middle part, which is the lumen profile, which is essentially a 3D multiplanar reconstruction of the coronary artery. And so what you can see is the stenosis is right here and extends up to the proximal vessel. And so what we did is find a landing zone just distal to that tight stenosis. Now, the way we do this is by scrolling for the most normal segment. And we'll actually notice that this here is actually our more normal segment. And we made our first measurement, which is 3.22. When we use EL guided criteria, we round down to the closest stent size. We know we need a 3.0 stent and a 3.0 NC balloon for post-dilation. As we scroll through this from a morphology point of view, you're going to see some important findings. One, the types of calcium. So there's fibrous tissue, but here you'll see there's eccentric calcification that's very thick with wire bias towards it. So Rich, do you want to talk about how we tackle these very eccentric cases?
So first of all, one nice thing about Shockwave is that even though we may have created some fracture to the vessel, we can go ahead and shock this calcified area that wasn't fractured to get our best expansion. We also, if we had a bifurcation lesion or left main, we could wire both vessels, and angulated segments are not a problem. We use a lot of CSI, a lot of rotablator, but this is an ideal case with the angulation for Shockwave. As Z pointed out, we look for areas that are good landing zones. He showed you the distal landing zone, and then we look proximally. And then there are we try to match the areas distally and proximally the best we can. And we'll pick our stent length based on that. Here you have some nodular calcium, but it's not protruding as much as other nodular calciums. And it's probably around 120 degrees worth of calcium. Could you scroll somewhere else where we could show an area of calcium that's not fractured? Here we do have some fracture. There is fracture here in this calcium, but it's almost circumferential. There was one area I think that was not here, right here. So right there, it's basically almost 270 degree calcium. We can measure the depth of the calcium and the length. And as we pointed out in previous study, if your depth is greater than 0.5 and your arc is greater than 180, and the length is greater than 5 millimeters, there's a good chance that conventional balloon technology will not be adequate. We then go to some ablative technique. Again, here's some nodular calcium. And the beauty of OCT is you really can well see nodular versus superficial versus deep, fibrotic or lipid. So I think we pointed out, and we're going to use co-registration to magnify the angio screen so we can deliver our shock pulses exactly where we want. We go to 4 atmospheres. We don't take it to 6. We go to 4. And once we go to 4, we deliver the 10 pulses, and it's very well tolerated. You don't see any distal embolization. Hemodynamically stable. Your EKG is stable. You see these shock pulses, which are not clinically significant. But unlike other techniques where you potentially can have hypotension or bradyarrhythmias, this is very well tolerated, especially in the left main. Is quite nice. So I'm going to ask them to give me my distal zone, and it's a 12 millimeter balloon with 2 markers, but they're not. The emitters are not spaced at both markers. One is 2 millimeters in and one is 4 millimeters in. So we're going to move that balloon to get our maximal effect.
So we don't hear much from the panel. You guys have any comments for us at the moment?
Yeah. Any comment from the panel? Yeah. One of the
So,
things I was gonna say is I thought that the demonstration with the initial balloon and the dog boning was an important one.
the whole
Because,
time.
you know, there are times when you see angiographic calcification, but yet the NC balloon will dilate. And there's still an open question, though, whether going up high pressure with an NC is less safe, for instance, than going up lower pressure with the Shockwave. But I think we need data to sort that out. But the fact that you saw that up front tells you that you're going to probably need to use something else. The OCT amplifies that. And then finally, the points made about the angulation.
Pull back a little bit.
Because with wire bias and angulation and an aneurysm just beyond it, those are cases where even the most experienced atherectomy users are going to have a little bit of trepidation. So I think this is a great approach.
So I set my balloon up based on my OCT with co-registration, and we magnify it, and I could line the dots up exactly. I delivered 10 pulses. The Shockwave device lets you deliver 10 pulses, and then it rests, and then it lets you activate again. So we gave 10, he asked me to pull back a little.
So as Rich said, just to think about the geometry of the electrodes is important. Okay, so from the distal marker, right, we're going to have 4 millimeters until the first electrode, 6 millimeters till the next electrode, and then 2 millimeters till the distal marker. So you really want to try to get the energy immediately adjacent or perpendicular to the maximum calcium. I think and so what you're seeing is we move the balloon basically every 10 pulses. Rich has coined this pulse management. I think this is very apt because you're trying to get perpendicular to the calcium. And you can see already that dog bone area of calcification, we fractured it.
In terms of the size of the Shockwave balloon, you using 100% or you upsize or downsize the sizing of the?
Yeah, the manufacturer's recommendation is 1-to-1. Let's come back a bit, I think, Rich. Yeah. But we actually go a little bit bigger because we're only inflating at 4 atmospheres, so we cause almost no barotrauma.
Well, I tend to, after the shock, I increase by about 2 atmospheric pressures, like 4 up to 6, to just increasing the lumen a little bit.
So you can see the dog bone here.
I think the other thing that's important is that the best the balloon's going to be is when it's deflated. So that distal to proximal approach is important. Sometimes you want to go back and advance, and you can do it, but it's just harder at times. So that approach was a very good one and wise.
So we don't go to 6 atmospheres. The reason is, if you can see, it's actually dog boned here. You want to say anything for them, Rich? So we don't go to 6 atmospheres because you get 50 atmospheres of pressure from the acoustic bubble. So to add the 2 atmospheres, all it does is increase your chance of rupturing the balloon, which is an expensive mistake potentially.
In the trial, I did rupture a couple of balloons going at 6, so I've just gone to 4 and haven't had a problem. Here at St. Francis, we've done over 160 Shockwave cases.
And so I want you guys to notice how the balloon is yielding. It doesn't yield like an NC balloon all at the same time. It slowly increases its space by increasing the compliance.
So we've delivered 60 shocks, and one question is, how do you know when you're done? And the answer is after you image. So, I mean, I personally, if I've done my pulse management where I think I am, and I see expansion, I leave 2 pulses, 20 pulses left, so I could go back in if I had to. As you pointed out on the panel, it may be more difficult once you have used the balloon to get across, but I like to have some in the bank. And I think we're going to image and see what we have. The wire is any workhorse wire. We're using a wiggle wire here. I like the wiggle wire in these complex calcified lesions. It helps me get my OCT catheter across, as well as...
We love to see the OCT afterward.
So that's what we're going to do for you now.
So we every time we do a calcium ablation case, we do pre-imaging, if we can. We do post-ablation to document the fracture from the technique, whether it's orbital atherectomy, rotablator, Shockwave, or a conventional balloon. And then we image afterwards with a stent to look at dissection, luminal gain, and potentially stent apposition. So we do a minimum of 3 OCT runs on every case. And we actually use less contrast and less radiation than those who don't, because we're not taking as many angiographic pictures beforehand, since we know we're going to see a 360 picture of what we have. So we're across the lesion, and we make sure there's no contrast I always go manual to get a better run. Ziad will wait for me to say yes. Now, so I can see that my guide is emptying the vessel from blood rather than the automatic where it could just activate and my guide could pop out. So now we're going to look for fracture, landing zone, and size of stent. So you see we have very good fracture. And sometimes what we measure as our stent length changes with the Shockwave, because you can get longitudinal fracture, and the size can change as well because you sort of like release a girdle.
So what we're going to do here is just start off by starting off at the distal end here. You can still see that the lesion is tight. We might actually go back with our 20 shocks and try to hit that segment if we can. There's a little bit of chatter here. So we just want to make sure we're in the right section on the angiogram. You can see we're right across from this diagonal branch. This lesion is still tight. It hasn't really yielded that much. So I think we'll go back with our 20.
I don't think I went that far.
I agree.
Yeah,
I think we go back down with our 20. We'll go back with our 20, but let's just scroll through for you in the meantime. Can we have that Shockwave back, please? And you can see what we've got is some dissections, and you've got huge fractures here. So at 12 o'clock, basically, this thick segment of calcium that was over 1 millimeter is essentially fractured in half. These two plates will now act separately. So when the balloon and stent expands, it will create space in this area. So there's really not much more to do with this OCT. We won't overanalyze it because we're going to go back with our balloon. And in case we can't deliver the balloon because we haven't adequately prepared the lesion, we'll get another balloon.
The point being is that we're going to know what we're dealing with before we stent the vessel.
Well, this is an example of where, you may have even done an atherectomy, and then you might have even been tempted to go ahead and just put in a stent. But clearly we're not ready or prepared to put in a stent. And I'm going to ask my team to just get their hands on a 3.0 Shockwave balloon.
This was a 3.5.
In case we need, this was a 3.5.
Yeah,
but
so
this,
3.0.
yeah.
And the other thing too, I think that that folks will do, and we sort of do it routinely, is even after, if we see the fracture, I'd be curious, Rich, to hear, do you just put stents in at that point, or do you take an NC balloon and try to make sure it's dilated?
So I personally just put a stent in. I know some of my colleagues will balloon it. I love when I have fracture to have a stent in to protect me before I go high pressure. I think if I have fracture and I can deliver that stent, I'll be able to use a high pressure balloon. I'll get expansion. I know some of my colleagues don't do that, and they'll always test. I know when I do CSI and I see fracture, I always go ahead and stent. I know when I work with Jeff Moses, who works in our lab as well, he likes to check it out with a balloon.
We might have to rewrap this in the guide, Rich, if it can't go.
Yeah.
I'm just going to rewrap this in the guide. Bring it back. I think it's, yeah. I'm just going to rewrap this to at a couple of atmospheres to see if it can go. If it doesn't, we won't struggle too much.
No.
Do you want to try a guide extension first before a new balloon, or just for the?
Well, I think the issue is we only have 20 pulses left.
I think I may be there almost. Let's see.
Yeah, it's making progress. No,
not there. Not there. The other thing is this is a 3.5. I'm going to be more comfortable putting a 3.0
I think so.
anyway.
We oversized this.
Yeah. We did 3.5 based on the more proximal
we have the
areas,
3.0
and I
Shockwave,
purposely
please?
didn't hit that area because I was a little conservative about the size. So we're going to go with a 3.0 Shockwave. I think that's going to be a better choice than to muscle this 3.5 down there and potentially have a problem.
So what I'm going to do in the meantime is go back to the original OCT run and just walk you through our plan, okay? So what we're going to do to you here is demonstrate for you how we basically put a precision PCI into clinical practice. And so what you're going to see is we made a number of measurements. So we made a measurement at the distal reference where we can see EL, and the vessel size is 3.22. Now, distally, we know we're 3.22. We need a 3.0 NC balloon. We need a 3.0 stent. But proximally, we have a lot of choices, okay? So our choices here are to land at 28.
You can keep.
But if we land at 28, we're really at the edge of the lesion right here. So we might end up with a geographic miss. If we go to 33, we actually end up in a not so healthy part of the vessel with either calcium or lipid inferiorly. But if we actually take a 30 millimeter device, you can see that we've got ELTL, it's completely fibrous, and we've got complete lesion coverage. So we know that we need a 3.0 by 30 millimeter stent. We'll take a 15 millimeter, a 3.0 15 NC distally, and we'll take a 3.5 12 proximally. The reason we're going to use a 12 is you can see all these red dots. Each of these red dots is a branch. And so what we don't want to do is cross too many branches. And so if we go to the second branch, which is the larger of the diagonals, that gives us 12 millimeters, and that helps us do our pot.
The other thing, by picking the 30 versus the 33, I try, if I can, to have my areas very close to each other, if possible. Here you see distally it's 533 and proximally 678. When we went proximal, the areas were much higher there. I think they were in the 9s.
Z, I'm going to ask you a theoretical question. Because of that nodular thing that's there, do you worry that you don't get as good apposition with the shockwave to transmit the energy, and maybe in those circumstances it's something where you sort of deflate, reinflate, or go up a little bit higher than 4 atmospheres, or is it that's more just theoretical?
No, I don't really tend to do that. As you know, Ajay, we're going to present the concentric data at TCT this year at the shockwave session. So I think that's interesting data. I won't let the cat out of the bag, but what I can say is that shockwave works in essentially all brands of calcium. Rach, can you touch therapy for us?
Give you a little far. Yeah, it's good there. You like that?
Wasn't looking.
I like that. You guys like that?
If Ajay likes it, I like it.
Ajay, is that you?
Ajay likes it. Okay, good.
So good to see you.
I didn't hear you I didn't realize you were on the phone.
Okay, we're up at 4.
So we're going to shock now. We got that 3.0 there.
So, obviously you can see it's completely yielded already.
Yeah.
Just with 10 pulses. So, we're going to use all of our pulses as best we can. So, right after this, I'm going to give you guys a didactic lecture on the mechanism of action of shockwave, which I think has some interesting points that might relieve some myths. And also give you some tips and tricks about how to maximize your yield from this. Now, one question that might come up is, we spent a lot of money on this case, right? Because 2 balloons is expensive, but it's more expensive to have a restenosis in a heavily calcified lesion. So we really just do whatever we need to maximize our yield and get the best results.
And Ajay, I just won't go out to dinner tonight.
Yeah, it's the same price. Might be cheaper to get an extra shockwave balloon. So only on our last inflation will we end up using our extra pulses. It actually makes you wait 10 seconds so that the artery gets some time to breathe. That prevents the overzealous from leaving the balloon inflated for too long.
I think they put that in there because of me.
I didn't want to say that, but you said it. Okay, so Rich is going to show you pulse management some more. So going to come back a little bit here and try to straddle this lesion, but I feel very comfortable that we're going to have a very good picture here. Now, again, remember, it's not probably worth it to go to 6 atmospheres and risk popping your balloon, because if you add the atmospheric pressure that comes from the acoustic bubble, the difference is 54 versus 56. So that 2 atmospheres is probably not going to give you a lot of benefit.
I think we have enough here.
Yeah, do you want to just do one in the middle across that section, and then we can take care.
A little fraction, but okay.
Okay. So the question is, when do you know you're done? The balloon is completely yielding. You can see it looks good everywhere. We're just going to go and re-OCT. Just like a TAVR, we have all of our equipment here already. So we're going to get our stent prepped. Ajay, your question was about, do we use an NC balloon? Well, certainly you don't get any more atmospheric pressure. I think if you image and you see the fractures, you don't have to, but maybe if you're not going to image, you want to see the balloon yielding.
Yeah, no, and I think that the point you made about the additional benefit of the 6 atmospheres is really important because the only circumstance I could envision that might change is if you were undersized with your balloon to start off with, because for instance, you did an image or whatever, and then the vessel yields, and so you're no longer opposed, so you're not delivering energy. But if you've done the OCT up front, you know the vessel size, you know you're going to be 1-to-1, then the difference between 4 and 6 atmospheres, as Z said, is exactly only 2 atmospheres overall, which is de minimis compared to what you're delivering with the therapy.
And in the study, Ajay, they actually had us go up to 6 after we delivered the shock. So it wasn't really changing anything, you know?
Yeah. The other thing with the wiggle wire, which is useful, is that oftentimes you get caught on spicules. And so just gentle negative tension on the wire, moving it 1 or 2 millimeters.
Yeah, I move it back and up. Exactly.
Yeah, there you go.
That's what I'm doing right now. That's exactly what I'm doing right now. I'm jockeying it back and forth to change the wiggle, a different orientation. That's great for in-stent as well.
Can I ask a question?
Please.
Yeah, Chris Wong. Actually, after you have shocked those that have the calcified lesion,
Okay.
now the thickness of the stent that you're going to implant, does it make any difference in terms of the result? As we know that there are some stent, the thickness only 60 micron, while some of them may be up to 80, some 100 micron. So the thickness of the stent, does it make any difference in terms of the result of the expansion of those calcified areas?
The truth is, I mean, I don't think we know. I think to us, it kind of makes sense that you don't want something too thin, you don't want something too thick. So we're in the sort of contemporary range of 80-ish. We don't have Orsaro here, so we don't really use it. But your question is good. But honestly, I don't have a great scientific answer. So here you can see where we started, which was next to the branch. And now you can see that it's completely yielded. There's the fractures. Now this is really important, okay? Look where the fractures come. They happen next to the nodule, okay? And this is actually a very common finding. You see some indentation, but the reason is the path of least resistance is actually next to the nodules on the 2 sides. And you can see a deep fracture right in the middle. Another little crack here. When we actually go up with the stent, you're going to see that this is going to fracture even further. So we're ready to stent.
Except one thing, see, I'd like to remeasure only because I think our length is going to be longer. Look at our landing zone. I think it's at around 5,
so
6. Maybe.
So you can see that we're just distal to our branch. We might have either got plaque protrusion. So we're going to go a little bit distal. And so you can see we can again find a segment with ELTL. Still the same size device.
But I think we're going to be longer.
We're going to be longer, yeah. So
we may be at 33. Let's just wait.
So here you can see all of this is kind of pulverized. So what we're going to do is come back. We're probably going to need a 38 actually. So if we land a 38, that'll last us here. Now we can actually do an EL sizing, but there's a big size discrepancy. Nonetheless, I think we don't have a choice because inside of this, we've got some dissections. So can we have a 3038, guys?
So what's interesting is that our pre-measurements told us a 3030, and we increased by 8 afterwards, whether it's due to me not ballooning in the exact spot we thought we would or longitudinal fracture.
But you can see what we're doing here is, I'm just going to show you on the co-registration where we land. So we've marked the distal reference. You can see this area is stenotic.
Yes, Takashi speaking. Yes, just distal to the diagonal branch, I can identify some stenosis by angio and also the OCT, right?
So we're going to cover it.
Okay.
So if you see, I don't know if you can see our OCT, Takashi, our distal marker, which is where the magnifying glass is. That's where we're going to land the stent.
Yes. It's on the distal landing zone, right?
Yes.
Okay.
So we extended our original 33 or 30 millimeter device to 38 because we injured the tissue in the proximal and distal segments.
Maybe Z or Rich, you want to talk a little bit about what happens if inadvertently you don't get the vessel and you deploy the stent, you have an underexpanded area. There's some question of whether you should use Shockwave acutely in a fresh stent versus not.
We've done that. We've, I'm sorry, go on.
Better than leaving an underexpanded stent, but what are your thoughts on that?
and anytime you're doing something new, you're always listening to rumors of what people tell you to do and not do. And
30NC,
we
please.
tried not to do it, but we had a case recently where we had somebody who had a fresh stent and it wasn't prepped properly, and it just couldn't open up no matter what. And we went in and shocked it. So we'll see what happens if we'll use a drug-eluting balloon afterwards if it comes back.
That's right. I mean, I think the only theoretical risk is that you can sort of, disrupt the integrity of the stent and the polymer and all that stuff. But it's more, to me, more theoretical and worse to leave behind and underexpanded the stent for sure.
And it's a balance, right?
Yeah, and we didn't have a choice, actually. I mean, the stent was underexpanded. We couldn't leave it that way. That was our only option.
I think it's certainly safer than rotoblading it out.
Yeah.
Oh, yeah, especially freshly.
Yeah.
I still have a nightmare about a case that was so heavily calcified that I did orbital atherectomy and I couldn't see the stent inside it. And I inadvertently did a stentectomy.
We remember. You salvaged it well.
Luckily, I didn't lose the wire. I didn't let the fellows do any more there. I'm like, I'm doing this.
Okay. I used to go up to 18, but now I like to go up to 22 at least.
Is that because you're Jewish and you like to go high?
I did 18 initially, but now that I'm non-sectarian, I go to 22. That's my birthday.
Nice.
Do 21.
21.
But this is
my birthday.
I think, we've asked informally people, what's their
21
with NC balloons, and a lot of people will say the highest I go is what's listed on the package.
35, please, or 375.
And for calcified lesions, I agree, Rich. I think you have to go.
We're going to take the 375. That's all.
Yes, I'll take this out.
Yeah.
Yeah, I know. I mean, I see someone go with a high pressure balloon to 12 or 14. That's not really a high pressure balloon.
Right.
My birthday is 31st.
It's 31st.
You're 31st?
We don't have an inflated.
We need to get an OPN balloon for you. You know what you are, man? You're off the charts.
That's right. That's right.
So honestly, I mean, we made a fairly complicated case pretty simple because we just followed the algorithm and we did whatever the imaging said. That's why I think it's so difficult to do these cases by using an angio-guided approach. One other thing that we've really enjoyed is that we find that in patients with low EFs or complex medical disease, 18 there, that Shockwave behaves in a really safe and predictable manner. So we don't have anything to worry about pacing or things like that. We haven't had a shock topics problem.
Or distal embolization and hypotension. I mean, we've done over a dozen left mains unprotected with 10-second pulses, and initially thought we'd have to come down. We haven't had one instance of any hemodynamic compromise.
And that's also important because I think early on, before it was approved here, there was a lot of folks saying, well, you may need to put hemodynamic support in to be able to support the Shockwave. Now, the European colleagues and those in Asia and other places told us, no, you don't need to do that because they don't use hemodynamic support. But I think, Rich, what you've experienced is similar to many other people, including us, that patients are quite stable during these inflations, and you can always come down.
So I think our stent looks great. There's a little question at the distal edge of what's going on. It could be a step up, step down, but there's one way to know for sure, and we're going to do it. But you see, we don't take a lot of puffs in between. So really the OCT guides the procedure for us.
Just a theoretical question with the shock topics. Have you ever had an issue on an R-on-T phenomena?
No.
Which
to the best of my knowledge, there's only one report. It's a case report. We follow this closely, and I don't know of any other cases other than that single case that's been reported.
Yeah. So most of my physiologists, they always want to put defib patches when we're doing a Shockwave case, but we haven't had any of that.
You can get about 10 millimeters of mercury of blood pressure loss. Mm-hmm. That's kind of been what we've seen, and that was what was found in the study. But none of them were actually hemodynamically compromising.
Baseline was 200.
Okay, so this is a pretty darn good looking OCT. All right, so you have the OCT up. Now, you see the stent is automatically divided into two halves. The distal stent is 100% expanded, 106% expanded. The proximal is 90% expanded. We're going to use MLD max. So what we're going to do for M is we're going to look for medial dissection. By doing this, all we got to do is go and click the distal edge and quickly scroll back and forth. And you can see there's no distal edge dissection, despite it looked a little hazy on the angiogram. Okay, so we're happy in there. We're going to go to the proximal edge. Scroll back and forth across the stent, which is right here. There's no proximal edge dissection. There's some very minor miscalculated malapposition by the OCT. Actually, the beginning of the stent is here.
We take the struts.
Yeah, can take the
It's
struts off.
reading the swelling of the blood, so but that's why you got to look at
Yeah.
it first.
And so actually, Rich likes to take the stents off here, the rendered stent off. You can see if we come proximally, we will be able to see. So that's actually just artifact. The stent you can see is all up on the wall.
It just makes it
There's
easier for me to see
malapposition.
dissections.
There's a little malapposition there, but you don't worry about that because the expansion is so good, it looks great.
So what we're going to do is just play through this and show you what happens to the fractures. I'll go slowly. So where the blood vessel is going to yield is at these sites of fractures. See, the stent is actually very concentric. Here's an example of where the fracture, you'll have automatic or sort of predefined malapposition here. You can see a fracture here where it's pushing the wall away from each other. Another segment of where there's a big fracture and then you've got some malapposition. Another fracture here. But you know, these are very, very good areas. The stent looks good, the angiogram looks good, and there's no edge complication. So we are done. Unless there's anything else you guys want us to do.
Congratulations, a good result.
Ali, it's really good cases. All right, so I have a simple question, right? In some cases, we didn't do the pre-plaque modifications with non-compliant balloon, anyways, any shockwave, something like that. After the stent, a very focal portion would be kind of a unexpanded, unexpanded stent by outside calcium. For particular those cases, still shockwave can work for that.
Well, yeah, I think so. In fact,
first, and there are some unexpanded area by outside calcium.
Right. So I think Ajay brought this up, but the answer is yes. There is some electron microscopy data which shows that by delivering the shops, you can damage the polymer. Mm-hmm. But given that you have an underexpanded stent, the lesser of two evils is definitely to use a shockwave and to try to expand it. So it definitely does work.
Mm-hmm. Mm-hmm. Great. All right. Any other question?
Yeah.
If not, I'll see you guys in 5 minutes to give a lecture. I'm going to run to my office.
Okay.
All right.
Right.
That was a great demonstration.
Thank you very
That's
much.
really great to see you.
Yeah.
Thanks, Andy. Nice to speak to you.
Yeah.
See you in a second, guys.
See you later. Yeah, right.
All right.
Thank you very much.
All right.
Wonderful demonstration. Any comment from the panel?
Well, this is a very nice demonstration of how easy you can, do a case with the shockwave balloon in some cases. A case like that in the past, well, you cannot actually using a simple NC balloon to expand it or even high pressure balloon and achieve something that you really like to. So I think that's a very useful technique to, as I say, for those who calcify, heavy calcium, particularly, this is a very thick calcium there. So I think they demonstrate actually how quick, how easy. He has demonstrated step by step. But if you do it in like a daily practical cases, you probably finish it by 15 minutes, not like a struggle for an hour or so. So I think that really, if you start from start from finish. I mean, really quick. So it demonstrates it not just actually give you a really good result, it also save you the fluoroscopic time, save you the kind of hassle to deal with some very calcified lesion. So it's expensive, but also it can achieve something that within a very quick time. So I think this is something that amazing.
You know, one thing about it though is, you know, if it weren't for that aneurysm and the angulation, you know, for experienced atherectomy users, either rotational or orbital, you can also make the case quickly done because you know this is what I have to do. You do it, NC balloon, and then finish. So I think the key is whatever modality you use, the imaging really can help you guide it. And you just have to go from one step to the next and know what the algorithm is. That's why I think it was nice that he showed that algorithmic slide up front. That's how they're doing it. And it makes sense. And then it moves forward. It's just those cases where you sort of are, maybe I should do this, maybe I should do that. That's where I think people really struggle.
I think a very practical question is how many percent of your cases do you do the shockwave? How many cases? How many percent of your total cases?
You asking me, or do you want to go on the panel?
Yeah.
So we tend to use it much less frequently because the cost is very expensive. And I think, like you, our experience has been, and I'll tell you the circumstance where we've seen this is, for instance, all the pre-TAVR cases. As you know, we have a very high TAVR volume. A lot of these patients have calcification, and many of those patients do very well with NC balloons alone. So our mode is that we'll try an NC balloon first. If that doesn't work, then we'll go to the shockwave. Obviously, if it's very stenotic or we feel like we just need to use atherectomy up front, we'll just do that. And then the only circumstance where we go to shockwave first or earlier is if we have an underexpanded stent with multiple layers, because in the old days, you would do laser, rotoblader, and I think shockwave is much better for that. So my sense is that we're using it in a small percentage of our cases because we have good experience and use of either atherectomy or NC balloons. And certainly NC balloons is about, 40 times less expensive than the shockwave.
Okay, what about Dr. Wong? So you have a lot of experience.
Yeah. Right? Less than 10%, basically. Yeah. But in our lab, actually, I mean, we tend to use a simple balloon technique if possible. But actually, because most of our patients have CT core angiogram, so we know actually the calcium distribution beforehand. So we can predict which one we tend to or need to use Shockwave beforehand, particularly those heavily calcified circumferential, as you can see in the CT. So we can predict beforehand what we need to use. And once actually we start using the Shockwave, I mean, we tend using less and less the rotoblader or diamond technique. So actually, because most of our cases we do have a CA beforehand, so we know we can predict, we can know beforehand that we need to use the Shockwave. I think CTCA is also quite useful in our setting to predict which one that we might need to, which one we don't. But most of the cases we don't, but still we need. We love to have the Shockwave available because we don't want to get surprised. I think that's important.
Great. Dr. Lee, do you have any experience with that? Germany Lee?
Well, in Taiwan, we don't really have Shockwave currently. So we don't really have some experience it. And in Taiwan currently, for most of the calcified lesions, we still will start with balloon, NC balloon, or cutting balloon Scoreflex or a rotablader. We don't have Diamondback or either Shockwave or laser. Well, we do have laser, but we don't use it very often as well. But today, the demonstration today is very clear, and it shows how safety it is. Hopefully, someday it will come to Taiwan as well.
Dr. Akasaka, I have one question to you.
Yes, please.
So the OCT can show very nicely the calcification, but one of the most important information when we treated the calcified lesion is the vessel size. So the OCT cannot show us that the vessel size. So can you replace the OCT into the IVUS?
Yeah, it's a very important question. But anyway, we try to find a landing zone in the distal portion and proximal portion. Yeah, only a few we cannot identify the vessel. I mean the EEL. But, almost all cases, I could identify the EEL. Anyway, more than 180 degree. So we can speculate the vessel size based on such information. However, as you said, only a few we cannot identify the true vessel area. At that time, we try to use the lumen area, maximum lumen area, and always the quota size bigger stent and balloon we will select. It's my daily clinical practice. So SJ, let's move on the lecture from Diaz. Yes.
Yeah, you want to introduce?
Okay, Diaz, are you okay?
Yeah, I'm ready.
Okay, yeah, let's start the lecture from Dr. Giazali, entitled Mechanism of Action, Intravascular Lithotripsy. Yeah, Giaz, please.
Thanks so much. So I think this is quite fitting after just doing a live case showing the mechanism of action. But I think this is a worthwhile lecture for many reasons because it actually goes through some tips and tricks that can be helpful. These are my disclosures. Okay, so this is fall of 2009, Sunday evening in an hourly rental lab in Mountain View, California. This is a Macgyvered lithotripsy device, which we procured from eBay. The eggs are from a local grocery store or from John Adams, who's the co-founder's ranch. This is my iPhone 1. And what you can see is John Adams is saying something. It's doing something. It looks like it blew a hole in the backside. What we're seeing on the front side is the membrane, and the eureka moment, I think it's going to work. So this really was the eureka moment because we really rigged this on a lab, but what you'll notice is that the outside of the eggshell is broken, but the membrane on the inside is completely intact. And this was the idea whereby we could work hard on hard and soft on soft. And this is where we are now. The Shockwave intravascular lithotripsy device is commercially available. What happens is you have these expanding and collapsing vapor bubbles that create a short burst acoustic pressure wave. The acoustic pressure waves travel through the vessel and tissue and give you about 50 atmospheres of pressure from a single electrode. And the localized field effect creates fractures both in superficial and deep calcium. Now, to understand this, you really have to go back to the original lithotripsy, which is extracorporeal shockwave lithotripsy. So in extracorporeal shockwave lithotripsy, basically you have a wand that's on the outside of the body, okay? You have an electrode and a spark plug. And what happens is you create a spark on the inside of this electrode, but it sits what's effectively like is the reflector of a flashlight. This is called a parabole. And so what happens is this spark that's created, it reflects off the inside of the parabole or the reflector, and the energy gets focused. And that's how we can target something that's 15 centimeters away, the kidney stone, by holding something outside the body. And the mechanisms that work here are the first shock that is created by the short high voltage pulse, then the expansion of the cavitation bubble, and then some secondary shock waves and liquid jets that happen as a result. What you'll notice is that the pressure that's generated, 100 millipascals, that's somewhere around 3,000 atmospheres of pressure. You have a short negative pressure and then a secondary rise. Now, the mechanisms of fracture that happen in extracorporeal shockwave lithotripsy and in intracorporeal IVL are multiple. The most important one in shockwave is the compressive stress. That's the initial wave that actually hits the calcium and compresses it, leading to fractures that usually occur in a linear fashion. After that, you have a secondary wave that actually propagates through the calcium, creating a shear stress. That actually then hits the back wall and creates a spall stress and pushes the calcium back from the back wall inwards. sort of compressing it from the other end. And finally, you have some tensile stress from these microjets that go in different directions, and you have a squeezing stress that happens from the outside. And this is probably the best caricature that you can see. The shock wave hits it, fragments the calcium, it goes through the calcium itself, hits the back wall, breaks the end, and then finally you have a squeezing effect, which leads to a overall number of fractures. Now, if we compare extracorporeal shockwave lithotripsy, intracorporeal shockwave lithotripsy, and intravascular lithotripsy, there are some fundamental differences. The most important of which is the move from focused energy, which is like a flashlight, to unfocused energy, which is like a light bulb. There's no reflector in a light bulb. All the energy comes out equally and radiates. When you do focused energy, you get atmospheric pressures between 300 to 1100 atmospheres and very high negative pressures. And you can imagine if you had this amount of negative pressure in the coronary, it would actually pull the calcium from the back wall and tear it off of the adventitia with potential risk. The most important is intracorporeal shockwave lithotripsy and intravascular are much more similar. And the reason is you can get the catheter very, very close to the stone or the calcium in both situations. The peak pressure is about 50 atmospheres. The negative pressure in IVL is very low. That's important. Your depth of penetration is 3 to 7 millimeters, and the compression stress is the predominant force. This graph on the left side is very important because in red, you see what an extracorporeal shockwave lithotripsy does. The energies are huge, and intravascular lithotripsy, the energies are much lower. Now, while you might think bigger is better, it's certainly not the case for lithotripsy in the coronary because we have to have safety above efficacy, and actually getting down to these atmospheric pressures required quite a bit of engineering. You also need to understand about the field effect. Now, what happens is you have two electrodes, and the electrodes are diametrically opposing pairs, which means the predominant force facing is on one direction in one electrode and the other direction in the other electrode, even though the energy spreads like a light bulb all the way through. There still has to be a focus point, so they are facing in opposite directions from each other. And this is why we need to do pulse management. You also note that the field effect, the highest amount of energy is immediately perpendicular to the electrode with a loss of energy as you get away from it. What you'll notice in the M5 catheter, which is the peripheral catheter, is that there's one area, specifically the middle electrode, which actually has the highest atmospheric pressures and actually is 100 atmospheres. And the reason is this is the only electrode which has its own channel. In all other situations, you share the electrode or the channel between two markers or electrodes. So this has 100 atmospheres pressure and does not have diametrically opposing pairs, but all of the other electrodes share a channel. Now, this effective pulse management we touched on. Optimally, what you want is the balloon to be squeezing the artery, so you have contact between the balloon and the artery wall, and the closer you get to the calcium, the better. And what this happens is you're basically creating a tympanic membrane between the balloon and the calcium so that when the energy comes out, it's closest to the calcium. If you have space, meaning the balloon is undersized, what will happen is much of the energy can be lost in the blood. Much of the energy can be lost because we're not tenting or bracing the artery or the calcium. Pulse management is when we actually move the electrodes to try to make them immediately opposite of the calcium. Now, it's important to remember the electrode positioning. From the distal radio-opaque marker, the first electrode is at 4 millimeters, the second electrode is at 6 millimeters, and we are 2 millimeters away from the distal radio-opaque marker. So these are important markers when you're trying to optimize your calcification penetration, as you saw us do in the live case, where we continuously move the balloon by 2 to 4 millimeters each time we pulsed. So this is actually how it works. You have unfocused lithotripsy energy. This is the light bulb turning on. The energy is emitted. It creates a steam bubble. And actually, as the steam bubble collapses, it creates a large acoustic pulse. And that's the energy that's delivered into the artery. Now, it's important to note that the reason that Shockwave works and is hard on hard and soft on soft is because of impedance. If you take a lithotripter and turn it on in water, you don't even get a wave. And that's because the impedance of water is very low, but the impedance of calcium is almost 5-fold higher. And so that's why you're able to actually touch soft tissue, which has an impedance very slightly higher than water compared to calcium, which is many magnitudes higher. So to summarize the mechanism of action of intravascular lithotripsy, IVL is like turning on a light bulb. It's a sudden, sharp, focused energy that's turned on and off. And that's different to an ultra high pressure balloon that can reach the same atmospheric pressures, but doesn't have the same pulse effect. And a good analogy is this karate chop onto the concrete, which is sudden, sharp, and fast, compared to the ultra high pressure balloon, which is a weightlifter who slowly has to push this atmospheric pressure against the wall. Now, one of the mechanisms of action that's important, we all know, is calcium fracture. But I'd like you to pay attention to this micro CT, which shows that actually the fractures are not always linear. And actually what you have here is a little bit of a chip. Now, while you might think, well, I never see that on OCT, it does require a little bit of thought. And this is what happens. When you use a balloon, okay, you get the vast majority, in fact, all of your energy based on compression. And a compression fracture is parallel to the applied force. But when you have tensile force or shear force, those cracks actually happen perpendicular to the applied force. That's why a balloon behaves in this fashion, but IVL probably happens much more in this fashion. And that's because of the multiple mechanisms of action. Now we're all used to these pictures, which are the linear cracks that we can see in the calcification, and it's much harder to see these chips that might occur in the calcification, but it is likely that they do occur. The mechanism of action is clear. By leading to calcium fracture, we can actually separate these tectonic plates away from each other, and when we place a stent, we actually push the calcium away from each other in multiple directions. There are multiple sub-studies, including the Disrupt-CAD 1 and 2 studies, which all essentially show the same thing. The more the calcium, the more the fractures. The less the calcium, the less the fractures, but the less the calcium, the less you need fractures. The Disrupt-CAD 3 OCT sub-study, which presented by Richard Schlafmitz, showed the same. So in summary, the Shockwave IVL system is very easy to use. You get 80 pulses from a coronary catheter in a 12-millimeter balloon that's compatible with a 6 French guide and a crossing profile that's similar to a non-compliant balloon and perhaps even slightly lower than a specialty balloon like an Angiosculpt. Now, I won't belabor over this chart, but you can see that there are multiple potential benefits of IVL over atherectomy. And many of those include that you have your choice of your own wire, you eliminate the possibility of wire bias, you can protect side branches, the risk of embolization is very low, the risk of perforation has been very low, the arrhythmias cause minimal hemodynamic impact, and you have an effect on both superficial and deep calcium. So in summary, IVL utilizes electrical energy to generate acoustic pressure waves, which impact the calcium. The acoustic pressure impacts calcium by multiple mechanisms, which I showed you. Compared to ESWL and ISWL, IVL energy is lower, in keeping with its goal to fracture but not pulverize the calcium. It's very important to have an adequate balloon size to 1.1 or 1:1. You have to understand the spatial placement and separation of the electrodes to help with pulse management. The mechanism of calcium fracture is the acoustic pulse, which is switching on the light bulb, sharp, short, and sharp. And in vitro and vivo studies confirm calcium fracture as a mechanism of improved vascular compliance. So it's clear that IVL is going to be a very important tool in the modification of calcium. Thank you very much.
Thank you, Giaz. The very fruitful and meaningful lecture. Thank you very much. We could get lots of information. So we'll have 10-minute discussion. Is it okay, SJ?
Right, fine, why not?
Yeah. Any question or comment from the panel?
I have one comment is, with all the experience, I think the preparation of the balloon is extremely important. Level lift air bubbles inside the balloon, because it kind of pressure they create, it works to become an explosion or like a bomb actually exploding. So the preparation of balloon, you always actually need to withdraw and with dye and withdraw many times, and at least 3-4 times before you actually sort of close it, because if there's any air inside the shockwave balloon, it is quite dangerous to my personal experience.
Thank you.
So Ziad, actually, what would you do if by chance when you inflate to 4 atmospheres, you see an air bubble inside the shockwave? Is that a no-no to then use the pulses, or what do you think?
So I don't pay any attention to it, to be honest. So I'll tell you a funny story. If you go back to the first ever IVL paper, which was published in JACC Imaging, I actually labeled air bubbles that I thought were the shockwaves. And so we didn't know how big the bubbles were. So we actually thought that the shock would create these tiny little air bubbles, and that's what the shockwaves were. Now, subsequently, obviously, we know that they're microscopic and can't see them. But I haven't really paid attention to the air balloons that much, the air bubbles that much, and I hadn't really thought of it in that way. I'm not exactly clear how the physics of that would work, but I'll make sure to pay a little more attention to it.
Yeah, because based on the Boyle's law, sudden expansion of the air bubble actually is much higher. I mean, in terms of the volume, is much higher than the liquid. So that's why I always actually pay attention, not to make sure there's no air bubble inside there, because based on the Boyle's law, it's actually the different pressure that end up different volume, basically.
Thank you.
Did you see a problem when you did that? Because this is not something people talk about, so I think it's worth discussing. What happened when you saw that?
Well, I mean, actually, I haven't done any experiment on that, but if I saw that, I tend to repack the balloon harder and harder. Yeah, I always worry that some explosion inside. I've done it in physiology as well. So I have done direct DC current ablation on the AV node. Every time you shock it, you basically create an explosion inside the air. So because the air actually expanding a lot quicker and faster and bigger, so you create a lot more barrel trauma. So I always worry about the barrel trauma inside the balloon, inside the vascular structure. So that's why I always actually make sure that it's well prepared beforehand.
Yeah, I mean, I guess it makes sense to prep it well. The thing that's tough with new devices, though, is that there are these case reports and things that come out there, and whether they have clinical significance or not is something to you need study to do. But what has been shown, at least thus far with Shockwave, is that all the studies that have done to date have shown it to be pretty remarkably safe. So I think the question is it certainly makes sense to do it with good technique. And that's also true with an NC balloon, because you can get a pinhole rupture sometimes that way too. So good technique is always important.
Can I make a small point with regards to preparation of the balloon? What I have done recently is I carry the balloon across the lesion without actually connecting it to the indiflator. And the profile of the balloon is not altered by changing by connecting the indiflator beforehand. So once you've crossed the lesion, then I connected. The other question I had for Ziad was, obviously with your experience, you would have had a few ruptures. I mean, even in my experience, I've had 3 or 4 balloons that have ruptured, and they sort of give you a lot of discomfort when that happens. One, you've lost your hospital a lot of money. The other is, I wonder whether there is, like Dr. Wong said, that there is air inside, and when this balloon ruptures, it creates a very different kind of dye loss from the balloon as compared to a NC balloon rupture, which goes like a pinhole. So just trying to minimize that risk of balloon rupturing we have sort of reduced the amount of pressure, like you said, just keep it at 3 or 4 atmospheres. All you need is just gentle apposition and let the shockwave do its bit.
So when we examined the pinholes, sorry, the shockwave ruptures, they're also pinholes. So it's not a pulverization or explosion, and it's usually the interaction of the plastic against a calcified nodule or spicule. So the mechanism seems to be the same. Now, I know in India, you have the thinnest version. So this was an iteration. So when it started, it was thick. To reduce the profile, we reduced as much as possible. Got it very, very thin. Then it started rupturing a lot. And so we actually went back to the middle, and now there's an intermediate thickness of the balloon which ruptures less. You just don't have that quite yet.
I'm actually sitting at 2 a.m. in the morning in New Zealand, not in India.
Oh, in
but
New Zealand.
Besides the point, so maybe we have the same balloon that they have in India. But yeah, I mean, I've seen a couple of cases where the balloon has ruptured, and it has given quite a discomforting feature, of almost like a pulverization of the contrast and the air inside, which has really sort of exploded out. So that has made us a little bit more cautious in the amount of atmospheres that we use. And also, I don't know, it's a very small point of preparing the balloon once you're across the lesion, rather than preparing it up front and then having the risk of the balloon not cross.
So I will in that share a very short experience that we had in Germany when we were doing original testing. If the electrode is not wrapped by the balloon, you won't create an arc because you need ions. So the way we learned that is in Germany, they use non-ionic contrast. So if you use 100% non-ionic contrast, which we inflated in the balloon for the peripheral studies, the shockwave wouldn't work. It wouldn't create an arc. And so that's actually a little safety mechanism that if the balloon ruptures and there's no ionized contrast medium next to it, it will not create an arc.
Okay. I really thank you for joining us, and it's a great new toys, new weapon to our interventional field, and we're going to see what's happening in the future. So, all right, Dr. Akazuka,
Yes.
could you summarize and close this session?
Yeah. Today we had a very wonderful case presentation, a live case. Yeah, we really enjoyed it very much because the rotablator or orbital atherectomy, we need some technique, right? Especially, but shockwave, it's quite easy to do the PCI without we do have some tips and tricks, but it's much more easy and very safe. So we will change the procedure. That the shockwave might be the game changer, I think. And the other clearly demonstrate the mechanism, and his lecture is very wonderful to understand the mechanism. Thank you very much. And all the panelists give us a wonderful question and discussion. We really enjoy this session very much. Thank you for giving us a great chance to see the wonderful live case and the wonderful lecture. I appreciate SJ for giving us a great session. Thank you very much.
Thank you all. All right.
Thank
See you in
you.
the next meeting.